Okay, and we are live. We are live on LinkedIn primarily, but also you can find us on Facebook and even on YouTube. So we're back for another live recording of the Nursing Home Podcast. And today we're going to discuss something that is a pain point. I can speak from personal experience. I'm sure some of our listeners can relate to this as well. A nursing home thrives and survives, especially today, on their short-term Medicare patients who are coming from the hospital after an acute stay. They're coming to the nursing home. They're going to get rehabbed, in talking industry term, meaning that they're going to get some therapy, they're going to get stronger, better, and they're going to be sent back to whatever their communal setting was. Challenge that we have many times is that they sometimes, a lot of times, they have more than one thing that's wrong with them, and they can have breathing challenges. I'm talking non-clinical on purpose, but breathing challenges they become acute very quickly. And a nursing home that worked really hard to get an admission or to get that referral, and they built up that relationship, and they rented equipment and set everything up, and then only to find out the next morning that the person was sent out because there were some breathing complications, and that doesn't have to happen. So today on the show, as you may see already, we have Eric Harter. So Eric is the CEO of Rapid CPAP. Rapid CPAP is a full-service respiratory company serving nursing homes, hospice companies, medical supplies companies that don't do respiratory. They specialize in stopping unnecessary readmissions back to the hospital. So today, Eric is an authority to discuss this very topic. So Eric, first, welcome. First of all, thank you. Thank you for coming, and welcome to the Nursing Home Podcast.
I appreciate it. Thank you so much. I look forward to chatting with you today.
Yeah, likewise. So let's jump right in here.
Yeah.
Describe the problem as you see it for hospital readmissions or unnecessary hospital readmissions.
Yeah. So, like you talked about, I know that you are an administrator, have been an administrator. Maybe you're on hiatus, but I've listened to the pains of people in your position, directors of nursing, business folks, that they have worked really hard to differentiate their building as somebody that can take care of these patients from their referral sources. And, you're in essence begging and pleading and saying, listen, what we've done, we've made improvements, we've educated, we've done so many things. And, we haven't received a referral for some time. Please give us this patient, this complex patient. I assure you we'll take care of them. And then the administrator goes home and they're tossing and turning through the night, maybe thinking, boy, I hope Mrs. Jones did okay. And, I can't wait to see what happened in the morning. And then you get into the building, you have your cup of coffee, and you go into your office and you have a message on the answering machine. I'm kind of dating myself. I don't know if we have answering machines anymore.
Whatever. You get an email with the message, right?
An email, right. So, or you get up in the morning, you check, and the first thing is, hey, Mrs. Jones went back to the hospital for shortness of breath. And unfortunately, she was only there for 6 hours. And you get the referral center calling saying, what happened? Why did this happen again? And guess what I'm going to do? I'm going to send my patient to somewhere else. So that's like a conversation that I've had many, many times. And there's a lot of pain there. So I totally understand from an administrator standpoint, like that pain and trying to not to want to have that happen.
Okay, fine. Very, very, very fair point. And like you said, let's call a spade a spade. The nursing homes, especially now, unfortunately, one of the biggest challenges that nursing homes have right now is census. Unfortunately, COVID decreased the census dramatically in many, many facilities. And not only that, they're not getting refilled, if you will, by other residents because many people are either opting not to do elective surgeries, or the hospitals are not allowing them to do elective surgery. So the census is still down. Census is like really down. So what's going to happen is we have to build programs. Now that's something that vague term used to always bother me. Like we're making a program. What does making a program mean? And do you really think the hospital case managers are dumb enough to fall for another thing, which means that we have another doctor on staff that technically has a specialty in whatever area? Bottom line is, like you described, they want results. We send you a complicated patient, you deal with them, you keep them, you hold them. We don't want to see them back here, within a few hours or days even. If we want you to really, really care for them. So the problem is that they're going to have an issue with their breathing, have some respiratory complications. Now, when someone's shortness of breath, what can a nursing home actually do? I mean, that's a real problem. Nurses can go crazy from that, right? And rightfully so. I mean, it's a serious issue. What type of interventions are there that a nursing home can do to avoid this? And how could it be practically implemented 24/7?
Sure. So really and I don't want to oversimplify, but the truth is there's really three things that you can do. First of all, you have to know who you're getting, right? You have to really identify who it is that you're taking, because we all know that the report from, or the liaison gets a report to the nurse taking care of the patient in med surg at the hospital is now giving a report to the nursing home nurse, and then we end up taking the patient, and then whoever comes to the nursing home is very, very different than the report that we got. So with that, no matter what, they show up your door, now you really have to take care of them, whether they're more stable or less stable. So now
let me just tell you that you're sugarcoating that part of the problem, and that's not limited to people with breathing issues. You know, this person is morbidly obese at 390 pounds, and they end up being 590 pounds. Now that's when real challenges start happening. But but so your point is well taken. It may be more complex. Assume that the patient may be more complex than what you thought, and if you could just barely manage, it might not be the best fit. But go on.
Correct. Yeah. So identifying who it is now that you have. Now it's game time, and you have to identify who it is that you have in your building and what you're going to do for them. And really, the second step is to be able to treat them. So you're going to have obstacles. You're going to have setbacks. You're going to have to overcome those things. And so for example, that breathing patient that you're talking about, somebody becomes short of breath, and they call, you have let's call a spade, like you said. Unfortunately, we have an agency nurse that now is 11 to 7. This is the first time she's walked into your building, and now she has the complex patient. We don't know how that happened. Of course, the administrator, director of nursing wouldn't ever want that to happen ever, but guess what? It happened. And so now we are in this situation. And so the agency nurse has the patient. She's doing her rounds. And listen, the nurses have a tough job. I mean, they have a cart full of meds. They got a ton of patients. They got to get this, primary care. The CNAs have to do the primary care. And so, but that doesn't leave any necessarily time to care for the patient that's short of breath. And so the patient that becomes short of breath, short of breath, huffing and puffing. CNA comes, tells the LPN. LPN gets on the phone, doesn't know the doctor, doesn't know the building, calls and says, what's going on? Patient's short of breath, and I'm short of breath, and the CNA is short of breath, and the nursing home administrator will shortly be short of breath. So then we decide, well, the doctor, it's 2:00 in the morning, and he says, well, short of breath, we can't get a saturation, there's huffing and puffing, send them out. So what are they going to, the question is, what are they going to do in the hospital? Right?
Okay. Awesome. Yes.
Yeah. So what are they going to do? And why can't we do it in the nursing home? So they're going to give oxygen. We have oxygen in the nursing homes. They're going to give breathing treatments, most likely, nebulizer treatment, throw them on a nebulizer treatment. We can do that in the nursing facility. We're going to most likely, let's say it's a COPD patient or emphysema patient, what have you, long-term lung patient, we're going to probably put them on BiPAP, right? So we're going to put them on BiPAP. We're going to give them positive pressure ventilation. We're most likely going to give them steroids. We're most likely going, if they're now in some sort of CHF, we're probably going to give them a bit of Lasix. And then we're going to monitor them, heart rate and saturation continuously. And that's what we're going to do. And we're going to monitor them, and we're going to probably admit them for most likely a 3 to 5 day stay. Why can't we do that in the nursing facility? Well, I have staffing problems. Well, I have, the DON doesn't want to get on board with this, or we have, a problem with this type of, nobody wants to provide this type of care. You're going to ask a question?
Yes. I am going to ask a question. So first of all, I'm getting from one of the comments, Frida Sarusik. She actually has a company that does
I listened
telemedicine.
to
But
her podcast. It was fantastic. You guys
yeah,
did a
that's
great
right.
job.
So you probably
Yeah, I
heard
was
that.
really impressed.
Yeah.
I actually
So
sent a message. I was
yeah.
impressed.
Okay. So one thing that she's pointing out is that you need to have telemedicine. If you can have the doctor actually listening to lung sounds at 2 o'clock in the morning, and they're not being woken up at 2 o'clock in the morning, but instead they're on call and they're waiting and they're fielding calls all night because that's their shift.
Yep.
That's a different type of conversation than
Yeah.
if you're waking up the on-call doctor. Well, all they hear is, like you said before accurately, that the nurse who's out of breath because they're panicking.
Yes.
That's certainly true. But getting back to what you said, let's just, if you don't mind, no offense to any of the listeners, but maybe just for me, let's dumb it down a little bit.
Yep.
So the question, I like the way you framed the question. The way you framed it is, we're in the nursing home, the shortness of breath. The hospital's not magic. We think, oh, go to the hospital, everything's going to be okay. The hospital, there's nurses there, there's doctors there, there's equipment there. Might be a little fancier. They might have deeper pockets than the nursing homes do, but essentially, they do. They do. But at the same time, we can do stuff too in the nursing home. So oxygen, everybody gets, right? Oxygen is air, and you apply it to the resident, and they breathe better when they have direct oxygen, high flow, low flow, different things. But besides for that, Lasix. So can you just define some of these terms? There's Lasix, CPAP.
Yeah, so somebody that has a little bit of CHF, their heart's not working properly, which is a common occurrence in the nursing facilities. You take CHF patients, COPD patients, and that you listen to them, and they have what's called rails, right? And so it's a fluid retention issue, and so you give them some medication to eliminate some of that fluid, because the fluid accumulates in the lung, and then they become short of breath. So that's something that's very, very common. As you know, the nursing homes today, and especially with PDPM now, are the community hospitals of yesteryear. So if you're trying to stick to, and the virus has been absolutely devastating, right? But the truth is, we have an opportunity now, as a reboot, as a restart, to now re-identify your nursing home as, we've learned from this virus, we've applied new skill sets, we've created a new program, but in that program, we're going to produce results, and we're not going to unnecessarily send patients back to the hospital. So it's a great time for a new opportunity.
Yeah. So hold on. So this is like the elephant in the room that we haven't addressed, maybe purposely, because everyone else is it's oversaturated with content. But the truth is, right, we know that specifically with COVID, right, breathing has been a serious issue and at the forefront. And we've discussed this in other episodes, how sometimes people's O2 levels are going down to the point where the patient wasn't aware, which is one of the challenges with COVID. And they have numbers, in the 80s, and they're still talking fine. Then before you know it, they're on a ventilator. Yep. But what you're saying is something very simple. I've been discussing with other clients internally and other people within the industry. Census is a huge challenge now, right? And like we mentioned earlier in this episode, it's also a huge opportunity, right? If your census is lower, your nurses maybe have some extra time on their hands. Yes, staffing is a challenge, so you're not going to have extra nurses just sitting around, but use it. It's never going to be calm, right? It's a nursing home, it's the medical field, right? This is like you said, it's the next thing after the acute care setting is the community hospital of today. So I mean, the community hospital of yesterday, the nursing home of today. But the point is, use the opportunity to reboot, re-identify yourself, right? This is true in every business, right? Every business that took a hit from COVID, which was pretty much every business, it's an opportunity to say, okay, this is what I was pre-COVID. When COVID came, I did X, and now I'm Y, and I'm rocking it. So we want this is awesome. So right now it's a unique time, it's a unique opportunity. So if you're a nursing home operator, let me talk directly to you. If you're a director of nurses, if you're an administrator, a regional director of operations, whoever you are, and you're like every day pulling out your hair because your your revenue is not where it should be, and you're losing money, and everyone knows the reasons, and we know COVID, and we know that there's less people in the hospitals, there's less patients. That's great, but that's not going to help boost your census unless you do something about it. And this is a real solid, concrete thing you can do. You can right now, if you can designate yourself and stick out as a specialist in breathing care, I'm purposely keeping it simple, then especially in the world of COVID, the case managers are going to be, if it's true, if it's genuine, if you have the support and you have the training and it's real, it's not just lip service, you can really distinguish yourself. I just got excited when you said that. So but now, so on a nursing home level, how would this happen practically?
So, you have to educate the staff. You have to have a program. You have to be able to just simply identify, treat, and prepare. You have to get buy-in. But it's not a. Here's the thing, and I've worked in and around nursing facilities and hospices and hospitals forever. And anybody, listen, we're going to have an in-service. It's going to be on nebulizers, or it's going to be on the new fandangled device, NIOV, Airvo, Trilogy, which we have all these high-tech devices. First of all, I've been to these in-services. You just worked an 8 or 10 or 12 or whatever hour shift, or even for the night shift, even worse. We have lots of it. We do hundreds and hundreds of in-services every year. And you got somebody who just worked an 8-hour shift, and now they got to stick around for another hour for an in-service. So it cannot be done in a onesies, twosies type of thing. It never happens, but yet we continue to do this over and over and over again. You have to have full buy-in from a nursing facility, and you have to be able to track your outcomes. First of all, nobody's gonna buy into it if you can't actually prove that you're going to decrease the readmissions. And you have to be able to track and say, okay, well, we track everything and we make sure. So we take your, I'm just saying in general, whatever program it is, wherever it is in the nation, don't necessarily have to use us, but anybody that buys into a program that says we're going to be very intentional in terms of treating our patients in-house, and we're going to do A through Z, and we're going to learn this program, and we're going to document the program, and we're going to measure the outcomes. You have to have a full buy-in of the program. It can't be done in a onesies, twosies type of way. So that's something that absolutely has to be done.
Yeah, I mean, there are two components to what you said. I mean, one of them is the simple thing, and one of them is the simple thing of simply making an in-service that actually people care to be at, right? So meaning that you have to be aware of what the situation where the staff is when they're there. Like, did they just finish a like 8-hour shift or a double, and now they're staying for another hour for something that they really don't care about? And how engaging is the in-service? How practical is it? And also, have they been in-service on 1,000 other tools, devices, and programs that never went anywhere? So they're tuned off. And then the other thing is, like you said, are they bought into the mission? Why are we introducing this program into the nursing home? Why is this important for us to have this in the nursing home? How is this going to affect our lives? Now, if they understand that, and they understand that what we're doing is that we are going to decrease those readmissions. And from a nurse's standpoint, you're not going to have to panic at 2 o'clock in the morning because we have a whole slew of things to do. And the nurse knows that in addition to the tension and stress of the patient who's right now struggling to breathe, there's also the stress that tomorrow morning she's going to get it from the directive nurses or the administrator, hopefully, and say, like, why didn't you do this? Why didn't you do that? She's also thinking, let me make sure that there's nothing else I could have done. But now we're giving them all the tools, giving them all the support. This is what you need to do. This is what you can do. This is what's available. That's a way that you can really start implementing it in a way that actually works.
Yeah, absolutely. And at the end of the day, it's just, I mean, not to sound overly simple, but it's providing better care for the patients. Like, like everybody's had loved ones that, or we've cared for these patients for long enough, and we've built relationships with these people that just being at that stage in your life, and then the family, the family gets a phone call. Hey, we had to send mom out to the hospital. Oh, what happened? We were just at the hospital for the last 3 days, and we sent it to her. Now she's back in the, and then the patient's standpoint. I mean, these are in many cases the long-termers. These are their homes, so it's disruptive, and it's not a way to spend your final years. It's just not. So, going back to the education component of it, we find the best way to do it is to do gentle reminders, we call them, right? So if we have, you know, the in-service aside, so if there's an issue with a patient, let's say that you have a program, you have a person, we like to call them detectives that are going around looking for patients on day 2 versus day 5 when you have to send them out. So if I go in, let's say I go in, and technically I am a respiratory therapist, so I've done this many times, and you have to walk a gentle line. You have to be compassionate. You have to understand the nurse, what's going on with them at the time. But if you go in and you find that the oxygen is put in the wrong level. If I had $1 bill for every time I went into a patient's room and found what they call the oxygen adapter at the wrong spot, it should go here and it's down here. Hey, you know, Linda, let me grab you real quick. Just a real quick, gentle reminder. Let me show you this real quick. Actually, though, 2 needs to go up here, and now you'll see the saturation increase. Oh, thanks for telling me. Thanks for telling me. And if you do that in a non-threatening way, because nobody wants to, you got a letter from so-and-so, go and see the director of nursing, you did it again. If you can encourage folks versus just berate them, it's going to add to the care. It's going to decrease the readmissions by a significant amount. So that's really important, making sure that you are educating one by one, not just corporately, because I'll throw an in-service out in 5 minutes because, you know, again, nobody's listening or thinking about picking up their kids or thinking about, you know, what they're going to have for dinner, what is it. But if you can do it one by one and kind of act like, hey, it's between you and I type of wink, wink, nod, nod, but they get the education nonetheless. You still have to do all those things. And there are times definitely where somebody has to be held accountable for the errors and omissions that they've made as well. So that's part of the, you know, part of the process.
Yeah, but it's all about, you know, developing that relationship. And this is not limited to respiratory therapy care. And this has to do with any time you want anyone to do anything. It has to do with kids. It has to do with community members, colleagues, even bosses. But it's really fostering a relationship based on a clear structure, clear guidelines. And like you said, the gentle reminders, I like that. Hey, you just walk by.
And it's easier after, you know, it's like anything. I could still remember, you know, my first ventilator patient and, you know, our first code or whatever it was. And I was worse off than the patient, you know, and I was sweating and the whole thing. But after that, hey, we did it and it went well, or I need to learn this thing or whatever it is. You build confidence. If you're identifying, if you're, you know, who's at risk of going back to the hospital and taking steps to treat them in-house, and then preparing them is the other part, preparing them to go home. Like that whole transition from hospital to home, that the home part can't be forgotten either. What are the barriers? So, you know, you need to have a pre-discharge education program. You need to be able to vet them to make sure that they're not going to have any barriers at home. You need to make sure that they're educated as to, is there a change in their disease process now? Are they bought into making those changes? Or, you know, so and then you know, there's even some of our facilities and other facilities are making, they're doing home programs where they're making home visits. We have a respiratory telehealth program. There's other telehealth programs. I mean, telehealth is the thing now, but just like even talking about having a hospitalist on a telehealth call. Well, I find that because we're in such a niche, respiratory is such a niche, there's so many different types of machines out there that, no offense, the hospitalist is not going to be familiar with 95% of those machines. So if you can have a respiratory therapist telehealth in, look at the machine, look at the patient and say, oh, like I said, the oxygen adapter is in the wrong place. And oh, guess what? They're in the low 80s and now they're up to 93%. We just avoided that. We just avoided that patient going out, and even the cost. Even let's say you identify a nurse or a company or whatever it is, that you're going to have them be the respiratory detective, and you're going to have them identify, treat, and prepare these patients to go home. The cost of that person, even take that person at their whole salary, one patient that goes back to the hospital for a 5-day or 6-day stay is offset. So we're talking about a zero-sum cost, and we're talking about if you can do more than one patient, which is not that hard to not have patients go back to the hospital if you're being very intentional about it, there's no cost. There's no cost whatsoever.
Wow. Wow.
So I get excited about it because we've seen such great results, and I just am.
You should. You should. You have. But let's focus on this part of the conversation, because we spoke mostly about the transition from the hospital to the nursing home, but from the nursing home to the community is in general. That's another point of potential failure. So let's talk about what exactly that means for someone who has a respiratory challenge. So, assuming
Yeah.
you did a fantastic job, what
Yep.
does the worst case scenario look like?
Yeah. So here's the worst case scenario. So this is what happens 99% of the time.
Oh, boy.
Patient is at home on no BiPAP or CPAP. They go to the hospital for breathing issues or heart issues. They end up on BiPAP, right? That's the two pressures, the high pressure in, the low pressure out. But you're familiar with the difference between BiPAP and BiPAP's two pressure, CPAP's one pressure. Anyways, they get put on BiPAP in the hospital. Then the nursing home's like, well, they're on BiPAP or they're on CPAP or one or the other, but they're on something. And so then we put them on, let's say we put them on BiPAP in the nursing home. Well, now you have to have a home sleep test or send them to a sleep lab in order to qualify them or disqualify them. So now we're stuck, right? We're stuck in the nursing home. We have to get them qualified, and we have to work with a home care company. Hopefully they pick up the phone. Hopefully they call us back. But they're going to need a home sleep test to be able to diagnose that patient. Do they have obstructive sleep apnea? Now, many times they don't. Because they just got put on it for a short time. Mm-hmm. So we get ready to discharge them home, but now we have them on BiPAP, but we can't get them home. And so the home care company can't get a BiPAP out to them because they have to send them out to a sleep lab. Mm-hmm. Or it's going to take a 3-week time frame in order for them to get set up on BiPAP, 2 weeks, what have you. And so that's a major problem, because if they actually need BiPAP decreases carbon dioxide. So if you're we tune them up in the nursing facility, they're ready to conquer the world. We get them home. Now, every day they're not on BiPAP, their carbon dioxide levels are raising up and raising up and raising up. And that's a ticking time bomb. They're certainly not going to last. They're certainly going to go back to the hospital, and they're certainly going to do that inside 30 days. So we have to make sure that, there's devices out there, there's companies out there, there's programs out there. You can do home sleep testing in the nursing facilities and get that back within a couple days. It's not hard. And so, you can get, hey, this patient does have obstructive sleep apnea. And so us, for example, we'll work with the home care company and get over the home sleep test to them. Now we can qualify them. Now the discharge planner can get them the PAP that they need. And that's a big thing to overcome. Same thing with oxygen. Patient goes to the hospital, never been on oxygen a day in their life. Now they're on oxygen in the nursing facility, and we won't get them off. And we have to qualify them with like a 6-minute walk test, or we have to figure out, do they actually desaturate to a point that they qualify via Medicare guidelines? Are they going to be able to get the oxygen at home? And just that transition and making sure that there are no barriers. So it's the simple things. It's the things that we do over and over and over and over again, but making sure those I's are dotted and T's are crossed. So that's really, really important.
Amazing. I just see that we're coming closer to the end of this episode. So first of all, thank you for sharing what you've already shared. With your inside knowledge and actual hands-on experience dealing with this problem head-on every single day, for the transition from the hospital to the nursing home, from the nursing home to the home care company. Just before we let you go, can you tell us a little bit about how your company specifically works with the skilled nursing facilities? And then before we let you go, you'll tell us how people can learn more about you and your company.
Sure. So you can learn more about me. I'm on LinkedIn. We have a Rapid CPAP. We have a
Let's
Facebook
just say
account.
we're on LinkedIn for those who are listening. So it's at Eric Harter. Just put your
Yes,
name in, ERICHARTER, and they'll find you on LinkedIn. Okay, where else?
We also have a Rapid CPAP page on LinkedIn. We also have a Rapid CPAP page on Facebook. And we also have a web address, www. I heard you don't have to say www. It's just Rapid. I'm real good at the computer. Well, it's rapidcpap.com.
Okay.
So what have we done? Yeah. So at the end of the day, I could sit here and tell you how fantastic we are all all day. And obviously I love what we do, and it's a passion for me.
Let's talk specifically, how do you support a nursing home going through this challenge of managing someone with these types of complications?
What do we do specifically?
Mm-hmm.
So we have all of these programs, and we send respiratory therapists in to do all these things. And so we measure every outcome. We look at every new admit. We're detectives at the door, going through and just burying our heads in the chart, looking at the patient, doing bedside spirometry, evaluating them, working very closely with the nurse practitioners and the doctors to have a very cohesive relationship, writing recommendations. We don't write orders. We're not doctors. We're not nurses. We write recommendations for care. And 99% of the time, those recommendations are taken. Then we take that data and we measure the outcomes. And thankfully, the average nursing facility can be upwards of 20% for respiratory readmissions. We run around 2%. So the amount of revenue that's saved is tremendous. And so folks in the administrator position seem to like that.
Say those numbers one more time.
20%. I've seen much higher readmission numbers, and we are running at around 2%. 2%.
So when you say 2%, 2% means 2% total readmissions, or readmissions with a breathing diagnosis?
Cardiopulmonary diagnosis, which are the majority of the patients that are going back, right? So shortness of breath is one of the major things. So yeah, we've had great success with that, and it's been a real fun journey.
I think part of it, I don't mean to take any credit away from your company, but I'm just speaking from a nursing home standpoint. Nursing home operators, administrators for sure, and directors of nurses many times are in a constant state of being overwhelmed and overtaxing the extremely limited resources that they have to begin with. And I see you nodding because you know that when you come in, you're probably welcomed with open arms, because just having additional resources to tackle the problem. If we have to pay a nurse full time, and just to focus on this problem, we would be able to make some progress, not as much as having an outside company that specializes in just this and has respiratory therapists and everything that you guys do. But even that would be something. So partnering up with your company, it should be, and working together in order to manage these types of diagnoses, decrease those readmissions, should be something that's really welcomed. So again, thank you, Eric, for coming on the Nursing Home Podcast.
Thank you so much. I appreciate it. It's been a real joy. I appreciate spending time with you.
Okay. It's been a pleasure having you on as well. Remember, you can check out Eric's profile. So it's Eric Harter. You just put that in the search box in LinkedIn. Could go to rapidcpap.com. You don't need to put in the www. Google will automatically figure that out.
It's amazing. It's unbelievable.
Whenever someone says, like, I'm not good at the computer, it's like
that's when you know. That's when you know. Yes,
it's like, all right, guys, I'm really not good at the computer, which is on the desk over there.
Dating myself, yes, sir.
But again, anyways, all kidding aside, Eric is the man. Go check him out. All right, thank you, Eric, again for coming on. I really appreciate it. This podcast, as well as all the other episodes that we've had on the Nursing Home Podcast, are available at thenursinghomepodcast.com. And special announcement, Amazon Music just started hosting podcasts. It was just last week, Wednesday or Thursday, and yours truly is already there. You can say, hey, Alexa, play the Nursing Home Podcast, and it will automatically play the latest episode of the Nursing Home Podcast. Really cool stuff going on. The goal is to get this information to everyone, everywhere, who is in this space, meaning nursing home people, so that it should be very easy for everyone to get this information. So you can get it there also. And again, that concludes today's episode. Thank you so much for coming on the show.
Thank you.